R.R. Verma and Dr. Marin Paul to come to the dais and co-chair the session. Shall we start? So, good morning everyone, and thanks for coming for this session on this Sunday morning. So, we're going to talk about importance and benefits of communication skills. So the question is, why are we even talking about it? Let's look at some of the numbers. Medical errors are the third commonest cause of deaths in US. According to WHO, 25 lakhs deaths occur annually because of medical errors. Coming to India, there are a boggling 5 million medical errors which happen annually in India. Mind you, this is just the tip of the iceberg. There's hardly less than 10% of the medical errors are reported. So, communication skills or communication knowledge is not optional anymore because the patient is a consumer now and the consumer awareness is an all-time high. Demands and expectations are very high. Doctors are not put on pedestal any longer. We cannot have godlike complex any longer. There's lack of trust. Stress and aggression is so much in the people. You don't have to come to the hospital. You just have to walk on the Kochi roads or drive on the Cochin roads. They bring in all the stress to the hospital. Sorry. Social media, everything is streamed live, and we know how it incites violence. Again, some numbers for you. Approximately 70% of the legal claims for medical aid negligence happens because of communication breakdown or poor communication or miscommunication. I'm going to touch upon broader aspects, points here and there, and my esteemed colleagues will be talking about specific situations. Let's talk about OPD. Approximately how many or what time does a doctor take to interrupt a patient? Any guesses? 11 seconds. That's all it takes for us to interrupt the patient. And if we do not interrupt, or if we let the patient continue with their stories, approximately what time do they take to tell us? 80 seconds. This is on an average. There are, of course, exceptions, but we have been always taught to ask leading questions. We keep on interrupting. Why are we talking about this? I know exactly how you feel. Empathy, empathy, empathy. This has to be the mainstay of all our communications. And the communication doesn't start at the doctor's cabin. It starts at the gate, at the security post, then at the front desk, then doctor, nurses, lab technicians, pharmacists, and this is all healthcare communication. It's not just the communication between the two, doctor or patient. Communication should be there at all levels and it should be done properly. I draw your attention upon this. What do you understand? This is exactly how the patient feels when we talk in medical jargons. We talk about, capsular distension and pseudo-exfoliation and all that, and, nothing is understood. And at the end of the day, we are wondering, we told the patient everything. And how come? Even then they are asking us. There's a huge gap between what we believe has been communicated and what actually the patient has perceived. There's been studies which show that 75% of the orthopedic surgeons believe that they have communicated properly to the patient, whereas in reality, only 21% of the patient express satisfaction. Look at the number, 75% and where's 20%? That is the gap. Most of the medical litigations are due to miscommunications or poor communication. This picture says it all. We are talking something and the patient, gets into something else. it's not just what we talk, it's also how we talk. Only 10% of the conflicts are due to wrong words. 90% are due to the wrong tone. So how we communicate is also equally important. It's not just what we communicate. This is called paralanguage. The pitch, the volume, the rate. Are we going too fast? The quality. Are we shouting hoarse, talking softly? The intonation. Intonation is nothing but the voice modulations. All these are very important. And why do we need effective patient communications? It's not just improved patient compliance, leading to the better outcome. Leading to the better outcome, not just for the patients, even for the doctor, and also for the institution. How? How come better outcomes for institutions? Everybody is communicating in a proper way, in a good manner. Then there is good work environment. There's enhanced safety for doctors and all other healthcare professionals. Greater job satisfaction. And patient scores. We know that the Google reviews matter so much nowadays. What is the golden rule of etiquette? Do not do to others what you would not wish done to you. This is extremely important. Let's all remember this. So take home messages. Communication skills are not just about niceties or soft skill anymore. The therapeutic communication happens between healthcare provider and the patient. Clinical communication among healthcare providers. That's what I talked to you about. And this has got direct impact on patient safety, satisfaction, and the treatment outcomes. There's a need for medical auditing, even if it is a very small institution. Medical auditing is a must. Thank you so much.
Thank you, Dr. Suchitra. That was a wonderful and actually a very lucid and, we had a lot of take-home points in this. And because communication per se is a very large subject, it is very important to, listen to the same thing probably again and again in different languages, which is what this IC essentially is about. So now we have talked about language. Now let us hear from our doyen, Dr. R.R. Verma sir, on how you can use verbal and non-verbal cues in communication. Over to you, sir.
Good morning. I think I'll restrict myself to non-verbal cues because of the paucity of time. Let's try to understand the unspoken language of non-verbal cues. What is the relevance? What is the importance? It reinforces or sometimes contradicts the verbal message depending on the situation. It can influence relationships and trust. Suppose I come in and say, good morning. You also will say good morning. But then I smile and say, hi, good morning. And a bond is formed between the speaker and the audience. That's how trust and relationships form. And sometimes it can actually influence the outcome of the communication. Various types, so many types are there. The important ones are proximity, body language, facial expressions and eye contact, gestures, touch and tone of voice. Proximity, in my opinion, between a patient and doctor, 4 feet is the ideal distance. I'm saying, you wear this glasses for 1 year and come back. Okay, patient understands. He's standing 40 feet away. I'm saying, you wear these glasses for 1 year, come back. That physicality of the distance takes away the importance or the way he understands it. He said something, okay, right. Facial expressions and gestures are like underlining a word. They reinforce what you say. And eye contact, again very important. I look at her, wear this glass for 1 year and come back. She says, okay. I am looking at something, taking some files. You wear these glasses for 1 year and come back. That importance is lost. Touch is a little touchy subject now that Hema Commission report has come. Anyway, I'll go to it in the next slide. Tone of voice also more important. These three things, proximity, eye contact and touch, can vary through time, can vary through regions and vary through cultures. Okay. For example, in North India, they come and touch your feet to show respect. And go to Europe or Western countries, they shake hands or even hug. Here we shake hands or fold your hands like that. But hug is also coming. That's why I said it's changing with time. And certain times touch and eye contact and sometimes proximity is a little problematic with certain cultures. Now, this is very important, as Sujitra was saying. The volume, I say, you take this foreverly. But then when I say, you take this foreverly, that four is forcibly, it is getting into the patient's mind much more forcibly actually. And tone. Suppose I say, come, come, come. Come. All these comes are means different things. I mean, even the last come means don't come. Then this inflections, intonations, the way you twist the word, you prolong, lengthen the word, shorten it, and those little gaps, little silences you leave in between your words or sometimes sentences, they can be very important. Suppose the patient asks you, doctor, will my blindness be cured? You will say, yes, your blindness will be cured. Or you can say, yes, your blindness will be cured. Or you can say, your blindness will be cured. Or you can say, your blindness will be cured. All this again, the last one, there's an unseen but after that. These are all because of the word modulation also. And gaps. Shall I go a little into the Malayalam? My grandson brought a joke from the school. I liked it so much because it's so useful in communication teaching. The sentence is, Jonathan Kalan kude edukada mazhayathu poi. Okay, simple sentence. You try inserting two gaps. Jonathan Kalan kude edukada mazhayathu poi. The whole, the mood, everything is changed. So these gaps are very important. So the important thing is, non-verbal communication is equally important as verbal. It adds up on or takes away the importance. And even minute things like just squeezing your eyes or these little gaps you leave in between words that can lead to a better understanding or sometimes misunderstanding also. Be very careful. Thank you.
Thank you, sir, for that very interesting presentation. Now I call upon Dr. Sanita Satyam for building rapport with a pediatric patient. She doesn't need any special introduction.
A very good morning to all of you. And I really thank Dr. Suchitra for having me here and trusting me with this topic. And I am to speak about building rapport with a pediatric patient. And I would like to say that building rapport with a child is not at all a child's play, because children pose a different kind of challenge. Some children you might feel they are very meek, but when you try to examine them, they'll be very uncooperative. And most important thing is that you needn't have your order of examinations that right. You can try whatever is comfortable for the child, whatever is comfortable for you, and then you can collate your observations. Some children you might feel that they are very okay kind, but sometimes it may be very difficult to elicit clinical responses. Whereas this girl, she is very, very cooperative. This is a 15 diopter prism based on test, which is very difficult to elicit, but look how she is cooperating to that more than an adult. And you can see all that coming ocular motility differences in this child. As Sir rightly told, there is a very important role for our non-verbal communication skills. And the child, as they come into the consultation room, they are judging us whether to be trusted. Prashna ano. And they are all very familiar with going to hospitals for all this respiratory problems and plenty of injections. So they are actually trying to judge us. So we have to win their confidence and follow their leads. And in this way, I think most of the children, they say that there is no child who is unexaminable on a slit lamp. It is possible to do, but we'll have to find out how. We'll have to learn that art. And most important thing is providing, as human beings, the first and foremost thing is what we seek is safety. So for the child, it's very important. The child should feel, we are all safe with all the accreditations, but child should feel that we are providing them with a safe environment, non-threatening, trusting environment. And stranger anxieties develops in children, and our social or environmental structures actually reinforce. Being a medical professional, sometimes we are the people, some parents, when they come in, they want the child to obey. So the first thing is അനുസരിച്ചില്ലെങ്കിൽ injection വെക്കും. That puts a very bad mark on us in the child's eyes. So, and take your time and show respect to the children. And children are, they deserve respect. And don't think that they don't have an individuality, they don't have a personality. They do it, they have it, I think, more than adults. And that is an important thing. And be genuine in your interactions. I think as a parent also, if you are faking something, your children will understand. If you are genuine, it will be good for us and for the relationship also. And sometimes we say that usually the OP sister says, "Idu cheyidu kazhinja chocolate vaangichu tharam." That is a false promise. Don't go, you won't be able to fulfill it. And next time when the child comes, child knows that no chocolate is going to be given here. So don't make such things, don't say things which you cannot do. And be very relaxed and friendly and interact to the child as a person, and be very truthful in your interactions. It's possible to elicit whatever you need even when you are genuine and truthful also. And I think the children will appreciate it more. So this is a Down syndrome child. In the background, you can hear that Kake Kake Kudavide song, but audio is not there. That's okay. So any child can be, so you need to have special examination tools also. Like this is a lens bar. So if you do a refraction in a child with this comorbidity using a spectacle frame, it's very difficult to introduce the spectacle frame, to put one lens, the other lens. This is a lens bar in which you can have different lenses in order, and it is too easy to examine. And be authentic, and building connections with children is very important. And 1 month back, I had a patient from Ireland. So in a I wanted to build a connection. So I just asked him, "What is your hobby? What do you do?" And some connections are very difficult. He told me that killing ants. Killing ants, urumbina kolla. It's very difficult, very curious kind of job, hobby, but it's difficult to connect, but okay. And the commonality we have to win. And then setting boundaries, I would like to talk that don't touch children unnecessarily. We don't want us to be touched. We feel that children don't go and grab them, because it's a setting of boundaries is also very important. Even without doing all those things, you can examine a child. And touch is very important, I do agree to that. But as professionals, you don't want your OP sister to hold the child on her. That kind of things are not professional. But and children with special needs, especially with autistic children and children with cerebral palsy, even the touch is very painful for them. So don't go and attempt if you want to examine such things in a very professional way. So this is an old video, how to examine any child. So initially this child thought that it is okay, you can undergo a slit lamp examination. But when somebody is forcing him, my OP sister actually tries to make the examination easier for me, he doesn't want to do that. And then a lot of convincing has to happen here. So I'm trying to show him all this in a bit to put his chin over there. One more minute, I think, here. So this toy he is very fond of. Most of the children were fond of this toy, and so, but he is not wavering to this temptation also. And mother wants, mostly mothers and fathers, they would like to keep their children chin over there because they feel that they are wasting our time. Nothing like that. Be very patient to the child. And so the first phase, actually this is a one long unedited video. So I'm showing him, this is your chin. Okay. So I have asked his mother to let him off. Can you keep your chin here? Okay, now he feels that I am more okay with him and he wants that toy. Okay, let him have it. Can you keep your chin? So mother wants to bribe him for keeping the chin. So finally, he is very cooperative for my examination. And for the indirect examination also, one thing is that you have to be quick with your examinations. You cannot take a long time to find your, introduce the instrument, explain to him what the procedure is. And then you might have to use some restraint, but sometimes it's not necessary. I'm not touching him even while doing a indirect examination. It's possible to do that. So this is my last slide. Explain to the child what's happening. They appreciate that. And in case of spectacle choice also, ask the patient, patient has to wear, so he can make a choice of spectacles. If there are some issues with a child wearing a spectacle, try to talk with the child and get his problem and not with the parent. Celebrate small victories. And one thing is, be careful with patronizing. If you ask one day I told a patient that, see, number of children in your school are wearing spectacles. He told me, don't compare me with others. So that was okay. I thought that's not right. And then we say that if you do squint surgery, some parents say that you will be more beautiful. Nothing like that. Don't say unnecessary things. And the world is changing also. Children don't want to be patronized, and I think we should learn from them in that. Thank you.
Thank you, Dr. Sanita. Yeah, it's very important. Body shaming is very important aspect. So you can't talk about squint to the kids also.
Now I invite Dr. Soni to handle an aggressive patient. As far as I think, when they see Soni only, they will not become much aggressive. But anyway, for the rest of us, we can hear his inputs.
Thank you, Dr. Marin. And let me thank Dr. Sujitra Bhatt for allowing me to be in that. I was thinking about something else in between. Okay. So I was just thinking about how a patient can be, the normal patient can be made uncooperative. So I was just remembering a story when I was in Lotus, Coimbatore. So usually on the holidays in Tamil Nadu, the OP will be double the number. They don't have Independence Day, Republic Day, nothing. They'll all come. So it will be full haywire over there. So there was a patient who was sitting, who came at around 11 o'clock. And somebody put dilating drops. Patient is sleeping till around 3 o'clock. Suddenly some person from the reception came. Hey, in the patient, patient was sleeping. என்னடா இது இதுக்கு முன்னாடி வந்த பேஷண்ட் எல்லாம் போயிட்டாங்க. Suddenly, he started shouting. He would have slept till around 6 o'clock without any problem. So I think you can make the patient more aggressive by your behavior also. And like Suchitra had put in her this thing, it's all about communication, and the you in the communication is very, very important. And the common scenarios which happen, which we face daily, one is the waiting time for consultation. People think it's a huge wait and delay in the services, okay? And people may think people who came before me, after me, have also been seen. That's a common complaint. Spectacle related complaints regarding the problems with the spectacle, delivery of the spectacle, all these things. Surgery related, very important, and also service related, like how they are being treated before they are seen. Some of this may be genuine, and some may be just assumptions. Just like, the patient who came before me, after me, the first one would have gone for chai and come back. So, and then personality disorder. So, when you deal with these patients, you have to be very important, very, very clear how you are going to deal with it. So, especially when you apologize and you accept and, try to get empathy, all these things, this is very important. So, thanks Suchitra for these slides, lending me these slides. So, why do patients get angry? One is injustice, proper injustice, or they may assume that it is injustice. Injury, like hurting somebody's emotions, etc. Invasion and intention. Invasion is when the patient's privacy, freedom, autonomy, etc. are being, cut into. And intention is that, okay, there is an energy and determination to do something, react against the injustice. So, how does this, the aggressiveness start? One is the anxiety. Initially, you'll be thinking, first of all, you go to a hospital, you do not know, especially with the kind of corporate culture which is coming on, whether we will be fleeced, okay, are they going to overcharge, or are they going to force us to do some procedure? Then comes the defensive. Okay, at the defensive stage, they start reacting, then acting out, and then finally the tension will be reduced. So the defensive, the emotions take over the rational mind, and they start shouting, shouting at the technician, talking, this place is bad, this is not what this thing, and he will not pay. He'll refuse to be examined by the optometrist. So this is a defensive stage, and then all the others happens. So basically, there is always a storm before it rains, or you get into lightning before it. So try and identify. That is not up to you, to your staff, to identify potential candidates who are going to create a problem and end up in aggressive reactions, and they should be triaged. And you have to be watchful and communicate during the once you identify, you should communicate. If somebody is restless, talking to the others, what is happening, this place, this, that, try and communicate. There should be a floor manager or somebody who is responsible. And immediately, if something is happening, it should escalate to the next level, and finally the center head, and finally the doctor. So identify the reasons, ask them, observe the body language, and also listen to what they have to say before you say something. So always involve the staff and the management. So first, when you are aware that something is happening outside, gather the information. So what exactly is happening? Okay. Then confirm the facts. This all let it be done by the confirming the facts, etc. Call the relevant people. For example, if it has happened in the optometry, call the optometrist. Or if it is in the front, call the floor manager. Triage the patient. And first round of reconciliation should be done by the paramedical staff or the center head, etc., etc. And they should assure that things will be taken care of. Okay. No, we want to talk to the doctor. That's all. Yeah, it will be taken care of. We will show you. Okay. But you will be in the midst of a patient, and obviously he cannot run in. So keep them calm till at the end of it, it's you. Okay, so get all start communicating, call the staff, the management, the concerned departments, talk to them in brief, and then call the patient. By then you should be ready with an answer. You should have a mental plot. So you have to stay calm. If you fumble, gone. He'll sit on your head, and then you cannot go back. So you be very, very calm. Listen to them. Don't keep interrupting at all. Listen to their whole story once it is over, and don't ask them kainyo. Okay, that also shouldn't be there. Okay, wait. Okay, fine. Now, and don't be in a hurry to justify yourself, and don't try to make their concern lesser. Okay, we understand what is the problem. Okay, now you start talking about it, what exactly happened, and there is nothing wrong in apologizing. But whether it is their fault or your fault, you can apologize. But then the apology should be titrated. Like if it is something which is not your fault, you just say sorry, but then don't go on keeping this thing. Sorry, but see, this is what happened. Okay, the other one is that if it is that I'm extremely sorry, we will correct it. That's all. And the meaning of sorry, expression of compassion. That's the first one, that saying sorry. When expression of responsibility also, that should be a little more intense. And try reverse empathy. Yeah, because see, we are in such a situation. Today it was a very overcrowded OP. We couldn't do. I'm very sorry about this thing. So see, look at my plight. I'm leaving the patient at home. Most of the time they understand, and you tell them there are certain things which are beyond our control. And explore alternatives. Sometimes all the spectacle fellow wants maybe a refund because this thing. You tell them, let's look into it. Okay, we'll look into it and see whether we can refund. Okay, or do something about it. Never commit on somebody something which cannot be refunded, but you can always tell them, we'll look into it. I'll call the optical fellow, just talk to him. You please take him, check his centration, check his power, everything, and get back to me. Buy time so that we can settle it. So focus on the solution rather than the patient behavior. Even if he's jumping up and down, think what you can do about it. And always avoid being defensive. Even if it is your fault, his fault, whatever it is, don't be defensive in that. And this is, in a nutshell, I think we can go about, dealing with an aggressive patient. And size matters, actually, so it helps me a lot. Thank you very much.
Thank you, Soni. We'll have more in the discussion. Now I invite Dr. Marin Paul. Again, she needs no introduction. She'll be talking about managing patient expectations. Over to you, Marin.
Yes, thank you very much, Suchitra, for having me here. Now, having said that, can I have my slides, please? Yes, thank you. So, right at the beginning, I said, see, communication is about saying the same things in different ways, right? So, whatever we have already talked about, I'm going to rehash it, but in a different way. So, you know the current climate, there is a lot of mistrust. Medicine was a top down. That means the doctor was looking down like this at the patient. Now, we are hoping for a level field, but now literally actually we are looking up. So this is the change which has happened. So be aware of that. And why is patient satisfaction and outcomes important? Because I think Sujitra showed in the first slide, this has a very great importance or a great impact on our outcomes, not only in terms of financial, but also in terms of patient satisfaction and all the other metrics that we nowadays put into practice. Now, George Bernard Shaw, all those days back, had said that the single biggest problem is in communication is the illusion that it has taken place. You think it has taken place, and for them, they are completely at sea. So what is important is that you are setting expectations right at the beginning of your. So see, I will be talking to you from a perspective of a cataract and a glaucoma surgeon. So mostly it is like, it can be anything, like any part of ophthalmology that you're doing. So start from the expectations that they can, the outcomes that you are going to promise them. So especially when you're dealing with surgical problems or processes, or even, simply even a spectacle, you have to give them a clear idea of what are the expected outcomes and also discuss the limitations. So this means you are setting realistic goals. Sangati kazhinjenu shesham parayunnilum, it's always better that you are talking to them beforehand. So you have to manage these misconceptions that they have. So it can be very simple from, wearing for the first time a presbyopic glass, and they'll say like ellan pokatarchiyana. So yeah, that is there. I mean, you have to, the misconceptions can come from anywhere. It can come from, social media, their neighbors, or, many of them, the wives will wear their husband's kannada and come and say that it is better. So these kind of, multiple misconceptions are there out there, and it is your job as a physician to actually address them. And again, I'm emphasizing, please discuss the outcomes with them. And you have to deal with specific concerns, like the positive dysphotopsias or the negative dysphotopsias after cataract surgery is one of the commonest ones. And so you have to discuss that. Don't deny them that this is something which is, it's not important. No, validate their feelings, and you have to. So that is one way you are going to manage their expectation. And especially if you see it in the left eye, it is much higher. In right-handed patients, you can actually, when you do it, you can tell them. Sometimes you may feel this, so don't bother before you do the surgery. Now you have done everything well, but sometimes things go south. Happens. So how would you deal with unexpected complication or sometimes like suboptimal results? So number one thing is to reassure them, and if reassure them that yes, I am on your side, I'm trying to deal with this. So, and also you must offer them constructive solutions. I admit that there are some of them are beyond solutions. In that case, you just hold their hand and try to, like I said, if it's a posterior polar cataract, give them an idea it is not routine. So these kind of things are very important to be on the move beforehand. You start the process, that they are aware that yes, there can be a little bit of a problem, but you always say that I'm going to handle it to the best of my ability. And if something happens, this active listening part is really very important, because active listening means I think somebody had just talked about it. You let them vent, give them time to tell and state their process, and don't be defensive, be empathetic in your response. And empathy does not mean apologizing profusely or taking responsibility for what is not yours, but saying that I'm in your corner. And ultimately, at the end of this day, you have to get patient feedback, because this feedback is what is going to give you, there may be don't always assume the problem is always with the patient. There can be problems in your SOPs. So get feedback and, have continuous improvements in your processes. And as far as possible, nowadays, it's much more easier as well. So many other people are there. Always get second opinion, third opinion from within your own hospital, if possible, if not outside. And that spreads responsibility. And please understand patient diversity. It is not that patients are in cookie cutter. Everybody is the same. You deal with everyone the same way. Depending on their age, their lifestyle, their occupation, their expectations, their whole background may be different. Similarly, for a rural versus urban, again, the expectations and the way you deal with them will be different. Cultural and language barriers, I think Verma sir dealt with it shortly, but because of paucity of time, I'm not going to talk much about it, but can do after this thing. So when you are dealing with complex cases, please take your bail beforehand. Explain the complexity. Non-dilating pupil. Say you may have to use a pupil dilator or a iris hook, and again take a second opinion beforehand. So if the patient goes to two people in your this thing and says, we'll deal with it. But yeah, please be aware. And then you also have to make sure that the patient is compliant. So many patients of glaucoma, you think you have communicated the importance of giving drops and putting drops, but then they will say we never understood. And so, and to avoid litigation, do be careful about proper documentation, and always, if possible, involve a senior colleague in cases which are really going, really south. And final word on this is that, like I said, it is not always the patient's problem. There are a lot of people who overestimate themselves. As you have to have an idea about your skill levels, and so you cannot always say that this complication happened because the patient was wrong, or it is a normal complication. Maybe you didn't have the skill level to start with at the first point. This is something also we need to understand. And always, don't comment on somebody else's surgery, somebody else's treatment, and avoid boasting. This is the last very important thing. A lot of people, especially the youngsters, I find, once they are in a reasonably this thing, they will be like, oh, I can deal with this, there's no problem, I'll give you the best. Especially now, that with premium IOLs and etc., you are setting up the patient expectations. Do not do that. So thank you for your kind attention.
Thank you, Marin, for that wonderful talk. You covered so many points and it was extensive. Now I call upon Dr. Thomas Arun Varghese to talk about breaking the bad news.
Good morning, ladies and gentlemen. At the outset, I'd like to thank Dr. Suchitra and KSOS for this opportunity. Breaking bad news. Unfortunately, all of us have to do this from time to time. So what is bad news? It is a serious and adverse event which can have an influence on the patient's life and sometimes a bearing on the family as well. Fortunately, hopefully our patients, there's no threat to life, but it can include even a bad condition that they come with. For example, sudden loss of vision, and it may be a, say, central retinal vein occlusion. It is a serious event, and we have to break the bad news to the patient in such a way that they accept it and also have the right approach to it. A good rapport is very important because you never know which patient is going to turn around and bite us. So every patient, it is always to have a good rapport, and very often what we see is in the present day practice, especially the new generation, they are stuck behind the slit lamp, and very often there is no eye contact. So after you examine the patient, it is important you move the slit lamp away and have an eye-to-eye contact and chat with the patient. Understanding the patient mind. I was a patient recently, as you can see there, just a few months ago, and I really valued the way everything was explained to me. I don't think they did this because I was a doctor. The orthopedic surgeon came and saw me and said, your muscle is working. I had a tender Achilles avulsion. My muscle is working, but the force is not being transmitted to the foot, and so the foot is not moving. So patients really value doctors who communicate clearly and empathetically and provide thorough explanation and involve them in the decision making. So the doctor explained it to me, and these are the options that are possible, and then we made a combined decision. There are standard protocols for breaking bad news, like what is known as the CLORF framework, the 4P framework, and the most popular one is what is known as the Spikes protocol. And I'll deal with this in detail. The Spikes protocol stands for setting, the P for perception, invitation, knowledge, emotion, and summary. And we'll go through this one by one. And this is a time-tested method. And just like anything, the more we use it and practice it, the better we get at it. So the setting, just like Varma sir was saying, do not talk about things in the corridor or talk loudly to a patient in the waiting room. When you're giving a serious news to the patient, it can be, as I said, a bad diagnosis, or it can be something like a problem you had during surgery, maybe like a PC rent. You don't do it in the corridor or in the waiting room. You call the patient into your room. It is good to have a colleague of yours or maybe a senior most doctor in the hospital with you, or your paramedic, your assistant with you at that time. In this day and age, we have to be aware of our safety because we never know how a patient is going to react. So safety is of paramount importance. Also, it is good to have the decision maker in the case of the patient to be there at the same time. And it is advised that you should do this sitting down. You're both sitting down. You don't do it standing. And the chairs at 90 degrees. And people have obviously tried these different methods, and which is why they have advised these things. Moving on to the perception, it's always good to ask the patient, do they know what is the problem? For example, as I said, like a CRBO. So we said it's a problem with the blood flow in the eye. And assess their expectations and be realistic. So we cannot give exact numbers. So we have to be realistic when we explain it to them. And as I said, at each point, be guided by them in your discussion. Invitation. Even when we explain about cataract operation, some patients say, Doctor, please do the operation. So just like that, you ask them, would they like to know what the problem is? And if so, how much would they like to know? That is the invitation. And then coming to the actual breaking bad news, the knowledge. So give a warning shot. We say, we've had a small problem during surgery. Give little chunks of information. Be direct. Use plain language which they can understand. And nobody can give exact numbers or percentages. So always give a range. So the first thing they're going to ask you is, what is the chance that I'll get my vision? And you always give a percentage range. And at each point, check what they have understood. And sometimes they'll deny that there is a problem, or we have unrealistic expectations, and you have to address this accordingly. Emotion. People react differently. Initially, there may be denial, a shock, anger, sorrow. So these are different ways people respond. We are all aware of Dr. Balaji, oncologist at Kaveri Hospital, who was unfortunately attacked by the son of a patient, who is one of his cancer patients. So be empathetic, keep calm, and as I said again, safety first. We have to keep that in mind. Acknowledge the patient's emotions, and that really makes a big difference, and make sure you listen to them. Summarize. So at the end of it, please summarize what you have said and have a strategy for the plan ahead. So I'd just like to go through this again, the spikes protocol, the setting. So make sure you're doing it in a closed room without disturbance from a mobile. Have asked what the patient knows about the problem. Invitation, how much would they like to know? Knowledge, explain in simple language and be empathetic when you're explaining. Have a strategy and summarize and have a strategy forward. And as the patient continues to be in your care, it's a continuous process. Regularly update the patient and family members on the progress and address their concerns and involve them in the decision making. Thank you.
Thank you, Arun. And in the setting, I would also like to add that it doesn't have to be a closed room. I feel that there should be 2 doors actually. Suddenly, they can become, very aggressive after you break the bad news. So, doctor safety is also very important. Yeah. And as Marin was talking, corrective action and preventive action, it's called kappa, and preventive action is better than the corrective action, but sometimes we're forced to take the corrective action later. Marin, I think you wanted to talk something about the cultural setting.
So one thing about the cultural difference. So see what like Sanita was saying, especially nowadays children coming from urban or, they are actually more than the parents. I'm finding that the children are quite demanding. And also the children who are coming from abroad. So they have been trained to speak up and they have been trained to, voice their feelings. And it sounds a little jarring to me because they sometimes come up with, sometimes irritating ways they will. So last week only I had a patient who said, I told him about, going out and playing. And he was like, I live in Dubai and I don't have any place to, go out and play. And every doctor is keeping on saying, this is a 6-year-old child, mind you. So you should have tools to deal with it, how to deal with these kind of children, because this is not something we as, from our cultural background, this is not usually what we deal with from, especially children. We are tuned to dealing it from adults. But when the children come and talk to you like this, you are, somehow put off your normal rails, So I think that also needs to be very, very clear now that you can have aggressive children as well. Because this is a cultural difference which is coming up.
And thank you, Dr. Marin. Any questions from the audience? Or we have seniors, Agustin Vampili sir, Narayan Guti sir. Anything to add? Yeah. Yeah, in yesterday's OPL session, we had this colloquial round also. Yeah, that is true. And adding to Dr. Soni's joke, and once we, talk to the aggressive patient and they become calm down, and it's better to record everything. The point of contact and whom did we talk to and what escalated and who actually interacted, how it would have been avoided. All this, because we never know, after 5 years some medical legal case can come up. So all these records are very important. So better to record everything. No, I think hospitals should have a setup. Yeah. I'm saying not in the file. Not in the file. These were all should be confidentially kept, and but we should be ready. You see. Correct. Whatever you say is recorded and stored. Correct. That is a way to. Yeah, correct. But how many of us actually do that? And
I would like to add one thing on this. See, these are all like very easy to say, but when you come to practical this thing, the amount of data storage that you need to store all these video recordings is actually, I don't think, practically possible for, because we need, when we are doing this ICV, there should be some kind of takeaway for people which can be practically applied. So I would suggest that where you are expecting trouble, like, you know, you have a patient where who has a I mean, again, from a cataract surgeon's point of view, if if there's a phacodonesis or if the pupil is not dilating, please video record that conversation that you're having and keep it for at least 2 to 3 months, so that that's the usual period where you're going to likely to get trouble. So do that. But I think routinely having a video, because I think the IMA is also now recommending that you have video record and video backup for all consents. Hopefully Dr. Mahesh is going to come out with something which is more practicable for us. Taking, imagine every day you're doing 10 to 15 surgeries and you are taking video consent for all that. Where do you store it? That is, it is incredibly expensive, and it is just not, there's no ROI on that.
Dr. Narayan Kuti would like to add something.
How many of you know that that's just like a body language? There is an eye language. Have you heard about eye language? Just like body language. For the importance is, suppose somebody is in the witness box giving something. How do you know that he is speaking the truth?
By the movement of the eye, the nystagmus.
No, not the nystagmus.
Not the nystagmus, but the way
To the left, they are lying.
I'll tell you that when he is cooking up the things, your eyes will go up, and for the right-handed person, eye will go up like that. For the right hand, left-handed person like that. So when his eyes, when this will not remain, people think that it will remain like that. No, it is only for 15 seconds. 15 seconds. So immediately start talking, watch his eyes. If it goes like that, then he is cooking up, it's not correct. If he is telling the truth, it will go inwards and upwards. Inwards and upwards. It will not remain there. When he start talking, because his mind, when he strike his mind, only the body language comes. Not talking has no relation. His mind has got the relation.
Otherwise, it will be outwards and upwards.
Right-handed people, left-handed people, reverse. Same thing. Audition, some sound, something unfavorable. For example, you are telling that you are seeing somebody is playing violin there. You just imagine that, because you already heard violin sound and all. It's very familiar. Then the right-handed people, it will go straight horizontally to the left. Right-handed people. Suppose you are saying a bugle is being blown under the sea, because you are not exposed to the situation. Then the eye will go outwards, straight horizontally out. And another thing is, you are getting, somebody is revealing to you very bad, somebody died, your relatives or anything, emotionally this thing. And that cases, what will happen, that your eye will go down and inwards for the right-handed people. And another thing is some thing which is not exposed to like that. You are saying, what will you do if you are be elected the Prime Minister? Because you are not prepared for that. But naturally, I will go down and towards your right. So it's called eye language.
Thank you, sir. Thank you so much. So with this, we conclude our session. I know communication is a huge topic and we could just barely touch on some of the points. If anybody else would like to add anything? Okay, so we conclude this session. Thank you all. Thank you so much.